Hello, everybody. Good morning, good afternoon, good evening, wherever you are in the world. We're so grateful that you've joined us today. My name is Doug Fountain. I'm Executive Director for Christian Connections for International Health. And if you're new to CCIH, we are an international network of approximately 115 Christian organizations and 15 affiliated partners, as well as a few hundred individual members, all working in over 90 countries. CCIH's mission is to promote health and wholeness from a Christian perspective and provides opportunities for capacity building, networking, fellowship, and advocacy. Before we get started today, I would love to start us with a short word of prayer. So let's pray. Lord, we thank you for uniting us together and opening our hearts and minds to see the needs of people for whom you care, and giving us the focus to work together to share the vital work of Christian health services. As we meet today to discuss mapping and data, please guide our discussion and keep our technology working. Amen. Okay, well, today we're going to have a discussion with several panelists, followed by at least 15 minutes of Q&A at the end. As you come up with questions, you can do it all the way through today. Please use the Q&A box on Zoom to type your questions, and we'll answer as many as we can. Please do not use the chat. You can use the chat for any other discussion you want, but if you have a question you want us to actually answer, please use the Q&A box on Zoom for that. This webinar is being recorded and will be posted on the CCIH YouTube channel and posted on the CCIH website at ccih.org under resources, then faith-based global health. You will get an email with a link to the recording when it's posted. Now, a little bit more about our topic today. The questions about the scope and scale of faith-based health services globally and where FBOs provide those services are frequently asked and difficult to answer. Today, we'll frame the challenges and opportunities for Christian health asset mapping, discussing issues of quality, access, and transparency. We will also exchange ideas about what lies ahead for the future of mapping and what our role is in identifying the scope and scale of Christian health services. As we get started today, I just want to introduce briefly the four panelists that we're going to be discussing with and hearing from today. Barbara Campbell is Executive Director of the Dalton Foundation, where she develops and implements strategic programs and partner relations to support health system strengthening in contexts in which they work. She's very involved in Haiti right now. Barbara is the Vice President of CCIH's board and is co-chair of CCIH's Data and Mapping Working Group. Scott Todd is an independent consultant with over 15 years of experience in helping international health and development organizations apply GIS technologies to analyze and strengthen development systems. For example, he's worked very closely with health system mapping data with the Christian Social Service Commission of Tanzania and the Christian Health Association of Liberia, just to illustrate. Also today, Dennis Kinyoki from HAP. Dennis is the monitoring, evaluation, and data management professional with considerable experience in health, TB, family planning, maternal and child health, nutrition. He leads a monitoring and evaluation and learning effort for the Africa Christian Health Association platform, and he's also worked with several NGOs. And then finally, Edwin Sam. Dr. Edwin Sam is an experienced researcher and analyst on health systems improvement. He is a technical advisor with the Health Systems Research India Initiative and holds a PhD in health systems and policy and a postgraduate diploma in health management. Dr. Sam is also co-chair of our data and management working group and a consultant on our 30 by 30 health systems initiative, which you'll be hearing more about today. Really, thank you to each of the panelists who are joining us today. We're so grateful for each of you. Today's outline, the framework for what we're going to cover today is in these parts. First, CCIH's interest in this. Why are we talking about this? And then illustrate with that, talk about our new mapping working group and our own efforts to understand our members and where they are and what they do. Second is to mention, introduce a new initiative called the Christian Health Asset Mapping Consortium. What is it? What are some of the elements that are in development on that? And we'll talk about also its application, particularly in HAP. And then finally, look at a specific context of health system strengthening, looking at our 30 by 30 health systems initiative. So that's the flow for today. Just to set a little bit of the context for this, Christian health services are diverse and dispersed broadly. They reflect the health mission of the global church. They are valuable partners in and essential elements of local and international health strategies. There's pressing need for more information about those services, their scope, their location, their nature, and ways to efficiently contact them for partnerships. And several factors are driving this kind of initiative. Frankly, I find almost every week an opportunity to speak about the scope, scale, and impact of Christian health services. And I'm seeing that because there's increased understanding by donors and partners of the unique value of those services. We know the breadth and depth and sustainability of those services. We just have to tell the story about that. There is a desire to integrate faith voices in national strategies and global priorities. And there are opportunities to identify best practices that we can draw from. Unfortunately, there are really some serious lacking some serious gaps in data about health facilities, community programs, training institutions, and all of that. So this landscape, this graphic here, paints a picture of what we see as the breadth of the whole Christian landscape. And it's really interesting to me that when you talk to people, you say Christian health services, people wonder, maybe people imagine what that means from wherever they may live or work, or maybe their profession. And so you might see public health professionals thinking about community-based services, or you might see nurses and clinical officers and doctors thinking about Christian health facilities, or you might see clergy thinking about their own church-run health programs. And all of those are true. All of those are parts of the entire Christian health landscape. And in addition to those key elements are the supports for those. And these are demonstrated in blue: the health worker training programs, the drug and medical supply organizations that procure and distribute medicines and supplies, the health networks such as the Christian health associations that exist, and then of course the many international support partners that may be international NGOs, or they may be mission agencies or donation agencies that provide medicines and supplies. That, when we think about the Christian health landscape, it really is important to keep this whole picture in our mind. And so I also like to think of it, I don't like to think of it, I do think of it sometimes as it's like there are many artists painting a single picture, yet few can see it for what it is. We each are working on our own separate parts in our own separate places, but who's painting the whole picture? And that's what we are trying to do through this today. So with that in mind, first, it's helpful if we know ourselves. And before we get to our panel, I thought maybe just setting in context also, who is CCIH and where are we at, and what do we know about our own members? We've been doing a lot of work on this just over the past year. So this is some relatively new information about our members. 44% of our members focus on a single country. Well, that means the other 56% focus on multiple countries. 5% are academic organizations. 14% are associations or networks themselves. 14% also represent a specific denomination, such as the Adventists or the Catholics or the Anglicans or the Methodists. And so you'll see that's a broad picture of who the members are. Now the question is, where are they working? And we've had the data on our website for a while about where they work, and this picture gives it's a heat map that gives an idea of where organizations have some type of operation. And you'll see from this, the darker blue, set aside the US where they all have some operations, or many of them have some operations. The darker blue are where they have field operations, the darker they are, the more organizations there are that are there. The problem with this is it even doesn't describe the scale or scope of any specific organization. It's just there is an organization working in this country. So some organizations might be small, some might be very large. So what do we really know about them? The next part that we've been really trying to understand then is what do they do? And so we've been gathering information from our members to really describe what they do. And we see organizations falling into two main buckets and then a third one that overlaps. 64% of our members actually support local service providers. They're doing things like sending products or volunteers, or they're advising on data, providing technical assistance. They're doing some kind of capacity building for local service providers. 38% of our members are actually serving direct populations directly. They're actually on the ground providing direct services. I think that's interesting because that data flips some people's understanding of what CCIH is. That some people have thought that we're a network of mostly service providers, when in fact we are over half of our members are actually organizations that support service providers. And then of course, 19% of our membership actually does some of both. So they're counted in both of the other numbers. They're holistic organizations. We don't show here another statistic, which is that over half of our members are headquartered in low and middle income countries. So that's just another dimension of telling the picture. So you see, when we have this kind of rich data, we can actually help articulate not just who we are, but why we're different, or who we are and what makes that special in the world. So with that in mind, I've been so grateful over the past year, a couple of years, to be working with the kind of experts that we have on this call, starting with Barbara Campbell. I've already introduced Barbara, and I'd like to bring her into this conversation now. Barbara, I think we've really charted some of this territory. We came up with these buckets to help describe our members, and now we have a whole working group on data and mapping. I wonder if you could tell us a little bit about that and tell us about your interest in that area.
Yeah, thank you, Doug, and thank you for that great introduction and for holding this webinar, because as you know, I think mapping and really understanding what's going on is really vital in order to be really effectful and impactful in our work, and also just to highlight all the great work that's happening in the scope of it. So I've been privileged to be co-chair along with Dr. Sam, who's on the call as well, of the Data and Mapping Working Group. It's evolved over the past couple of years, and I think I'm really proud to say it's become really practical and I think helpful to CCH. But we really want to be able to leverage all the great expertise that is in the CCIH membership. We know there's a lot of members that have extensive experience, so we want to invite everybody that has that experience to come in and join us and participate in this group. We want to be able to provide data that Doug can use, like he explained earlier, where he's always in conversations advocating for all of us, and having this data really helps show the importance of not only CCH, but all the members and the work we're doing. We want to be able to support the members of CCIH as well by offering information. So if you're working in a given country, you can find out who else is working in that country, and there'll be ways to partner and work together. And I think that's really, really important. We also want to be part of larger efforts like the Mapping Consortium you're going to hear about a little bit later, which is really tackling a huge problem of, not a problem, but just the idea of what's going on with Christian healthcare all over the globe. So it's very interesting. And then we really want to we're really a practical group. We do want to work. We want to be able to provide data and share that as well, so that it can benefit others. I do want to invite everybody to join the working group or participate if you are interested in any way. We do meet on the second Wednesday every other month. It's not a huge commitment. It's just an hour, but we have done some of the work of the data that Doug just shared. The mapping group was responsible for doing that. We Probably y'all got some emails where we're asking for data. So if you get those emails, we encourage you to respond to them because it's really important for us to get this data on our members. It's very helpful. But all the working members of the group were part of collecting that data. So we invite you to do that. We also do help CCIH prepare things for the annual meeting that happens in June. We help with webinar topics. And I don't know, it's been a really good practical way to kind of work globally as a group to really help benefit CCIH. So.
Thank you, Barbara. I really appreciate that, and really appreciate the leadership that you and Dr. Edwin Sam are providing for us on that. Tell us a little bit about, just in a minute, your story, because you have a passion around this, and I know you have a whole other effort in Haiti to document services there. But why mapping? And is there something that you see as a practical tool there that you really want to build on?
Yeah, as you know, I definitely am passionate about mapping. I think it is absolutely, the Dalton Foundation, we are a funder, and then we also do seek funding to scale our projects larger and larger. And I think from that perspective, it's absolutely vital to understand what's going on. I personally believe that Christian healthcare in general is known for its quality. It's known for its staying power. It's also known for going that last mile, being in the places where no one else will go. But I also know in reality, if you're going to attract funding, if you're going to be sustainable, you have to be able to show your effectiveness and show your impact. And this idea of really, and we intuitively know that Christian healthcare around the world is a big part of healthcare systems, but we can't actually prove it all the time. And so I think it's really important to look at efforts that are really trying to really make that concrete and show it with some evidence so we can show the impact of this great work. Again, in our work in Haiti, definitely a passion of mine, but because we fund heavily there, we really just need to understand what's already going on, who the key players are, who the strong leaders are, to where you can most effectively implement programs. And so we've done a very extensive healthcare mapping project in the country of Haiti. With the data we have is absolutely incredible, not just demographic and service data, but also capacity data. What is the actual capacity of the facility to provide healthcare? It's very, very valuable for us.
Wonderful. Well, thank you very much, and really appreciate the leadership on that. And I appreciate the call for people who are members to participate in the mapping working group. That's our think base. That's where we can do our problem solving within CCIH. And so, Barbara, really thank you for that. I'm going to turn now to the next area, which is to talk or unpack a bit about this new thing that's coming along, Christian Health Asset Mapping Consortium. That's what we're calling it. And I'm wanting to be careful here because we are right now the Secretariat, but we are not the owners and keepers of this consortium. So we are listing here the founding entities that are helping bring this about, and I'll talk about the goals in a moment, but Africa Christian Health Association Platform, Catholic Health Association US, Dalton Foundation, International Christian Medical and Dental Association, World Council of Churches, and then of course CCIH is, we are all coming together to bring this about. Maybe I'll start by saying, why did this come about? And I can say that back at the start of COVID, there were a lot of calls, a lot of inquiries coming around where people were wanting to know who has the list of Christian hospitals or faith-based hospitals generally that need ventilators or that need oxygen supplies, or who has a list of the health facilities that we need to be partnering with. And most of us in the field would scratch our heads and say, well, I have a piece of a list. And somebody else would say, well, I've got a part of a list. And we just finally said enough. There has to be some bringing together to create some way to share information in a better way. Also, historically, I think many of us know the market share data that has been circulated that many of us continue to use. As recent as 2015, there was a Lancet article that summarized that Christian health services make up maybe 20 to 70% of health services in many low and middle income countries. that data really isn't very helpful anymore because it doesn't say anything about urban versus rural. It doesn't say anything about the specializations of services or how many of them are hospitals or clinics. It just really leaves more questions than it answers. And so having a consortium come together that has some goals that are intended to bring about improved data seemed like a good idea. So we'll be launching this consortium officially, we pray, in January. But this is just a bit of a heads up to those of you who are tuning in to know about this. So the goals, Kathy, if we could just move to the next slide. The goals of, whoops, did we lose the, maybe we lost the goals. I'll summarize the goal slide. Yeah, the goals of the consortium were to highlight information on Christian health services, identify, maintain, and share information about the data, improve representation of Christian health assets, raise support or technical assistance to improve data, create a learning community, and then foster partnerships that analyze data and apply it for program development. So I'm going to ask Scott Todd to come in now and talk about the founding of this and talk a little bit about some of the elements that are in formation, new features in development. So Scott, over to you.
Thank you, Doug, and thanks for that nice introduction and great overview on the consortium and all of these efforts. It's a real privilege and blessing to be able to be part of this. The consortium has been taking shape and formation over the past year, and have been having great discussions with the partners that Doug listed and described. As he also mentioned, as part of these efforts, we're working to, we've got several tools in development. These are information and data utilization as well as data improvement tools. A couple of them in particular that we'd like to talk about today. One of them we're calling the Christian Health Registry. This is a registry that's documenting current data sets to provide and give us a better picture on the status of health assets. The diagram that Doug showed earlier really paints a terrific picture of the breadth, the diversity, the complexity of health provision around the world, in particular coming from Christian health organizations and facilities. And when we talk about these health assets, we're not only talking, of course, about hospitals and health centers, we're talking about training centers and research institutes, we're talking about the drug supply chain, we're talking about churches and community efforts and programs, even from the largest hospital facility down to a mobile unit that operates in rural areas or in difficult to reach parts of urban areas. So these are all health assets. And if we're looking to be able to share information with one another, to coordinate our activities, we don't need to know the specifics about all of this information, but we need to know where folks are operating and how they're doing this, and what are the services, capabilities, and programs, assets, and resources, as well as the risks and challenges that they're dealing with. So these are some of the information issues that the consortium is trying to be able to help the community convey. And this doesn't come across in terms of specific data sets on health assets. What we're looking to do is be able to provide compiled, aggregated data on health assets to be able to paint some of these pictures of where Christians are working and how. And so on this slide, you see three different examples of what we call dashboards these days. They provide a map and some graphs and charts and information about these initiatives. These three dashboards all represent different efforts and initiatives, but they're all terrific examples of how data and information can be conveyed in graphic text and very descriptive ways to show the impact that is happening. You can see in one of the maps in the lower left part of the screen, this is a direct relief dashboard that was done for the Ebola outbreak. This is graphing data from 2018 to 2020. And you can see that there are points on this map, but these points are aggregating the information and data from different health facilities at the province, or actually in this case in DRC, at the health area level. And so each of these dots represents the consolidated aggregate of information that's happening within that area. Similar to the map in the lower right, this is a West Africa Development Indicators dashboard. So these are measuring indicators at the country level. And in the upper right, you see various hotspots that are happening with fires around the world. And these are all aggregated in areas similar to the heat map that that Doug showed earlier. So we're not looking to share specific information about health assets. This is aggregated information that we would like to be able to consolidate and provide back to inform our communities publicly. At the same time, members of the consortium recognize that there are times, there are emergencies and events when we may want to share specific detailed information with one another. And so part of this effort and this initiative with the consortium is to allow both things to happen so that data can be publicly shared, but also privately secured, and so that we can collaborate in ways that are beneficial to the community, but that make sure to protect the work and efforts of everyone involved. Next slide, please. This is another direct relief. Actually, this is a hub website that they put together for working with the Fistula Foundation and several other organizations. It's a really impressive tool for conveying a lot of information. And it's provided on a website overall, but it connects in with this dashboard that is pulling in information from a wide variety of data sets and providing it back to the user, showing a map in this case of where specific fistula repair facilities are located, but then also globally showing the numbers of doctors and facilities and beds that are available, so that people could actually use this tool to search for physicians and repair facilities. We don't expect any time in the very near future that the consortium will have data like this at this level of specificity, because we're looking to aggregate it at a larger scale and provide global information on a wide range of issues. But this is a good example of providing specific data in very descriptive ways. And I think I have one more slide. Now this slide shows several other examples. These are links that you can refer to. Again, they'll be provided. You can come back and refer to them in the recording after the webinar. But this is another dashboard on the left that you can see that's become sort of an iconic dashboard these days. It was a Johns Hopkins University tool that they developed early on in the pandemic to help people understand the spread of COVID-19 and where it was expanding, contracting, and to be able to monitor and gauge the progress of that. On the right-hand side, you see a couple of these examples that we've talked about, as well as several other links and examples to health information efforts that are going on right now to provide data, as well as data about the data. At the bottom of that list, you see a couple of really interesting efforts. Some of these have been going on for a long time. The Open Health Information Exchange, in particular, I believe, has been around for nearly 10 years, primarily led by software development organizations in global development that are interested in sharing and coordinating their data and information. And these sites have a huge wealth of information, even down to country level data sets on health facilities. And so I highly recommend exploring some of these resources.
Scott, that's fantastic, and we're so grateful for your leaning into this. You really are showing the depth of the work that's been happening in this field. And one of the things in our conversations early, as you were a technical advisors, we were bringing the idea of this consortium together. In my limited vision, I was thinking that different organizations have a data set, and we should know about the data sets, and that's maybe half of the story here. But what you're also painting a picture of is there are a vast number of other data initiatives that we want to make sure the Christian health assets are reflected in and are counted in these other efforts. So the fact, even on looking back at fistula, I think about all of the Christian facilities that are working specifically in fistula. Are they reflected in that data set? And we don't know right now. So those are questions. How do we make sure that these Christian health assets are reflected in these other data initiatives? How are they really reflected as the ministries of health roll up data to the WHO? Those are big things that we want to try to see improve, and will help us advocate for more resources in this world. So, yeah.
Yeah, that's such an excellent point, Doug, and something that I believe, that we've talked about in the consortium that we're really committed to doing is working to help Christian organizations around the world update and improve their own data, and to be able to share that upwards in ways that will ensure proper representation in these global and country level data sets. It's really critical in terms of the resources, assets, and the global coordination, as you know.
Wonderful. Yeah, thank you. Thank you, Scott. Really appreciate the insights on that. We're going to turn now to one of the consortium members, HAP. And Dennis, I think you can come on and tell us a little bit about your perspective of what's happening in HAP and what you're doing, and why the consortium is a good idea for HAP. Thank you.
Thanks, Doug, for that opportunity to speak about the consortium around mapping and what it is for HAP. So I'll start by maybe telling the people on this webinar what HAP is. HAP is a Christian Health Association platform in Africa with 43 members spanning across 30 countries, whose membership are divided around the Christian health associations, Christian health networks, and also drug supply organizations. HAP endeavors to create a network and a communication community for these organizations. It's a platform to provide joint advocacy and capacity development in healthcare provision, and also a way of providing partnership across the different organizations in Africa. So, why is the HAP interested in Christian health asset mapping? It is recorded that HAP has around 5,000 health facilities across Africa among its member organizations. However, it's difficult to be able to pinpoint where those facilities are, what programs they are running, what services they offer, the capacity, and what populations coverage do they reach to. So HAP is looking forward to creating some sort of a central repository of all these assets that they are within the member CHs. And also, we know very well that faith-based has reached to the poor and rural communities, and also it has so much resilience, and it provides the buffer in times of emergencies. Are we seeing clear representation of that when we're looking at maybe national statistics and national numbers around health provision, and that's one of the best one need by HRPs in this. So we want to see how we integrating it, the faith-based efforts into the national strategies and also global priorities with a perspective of the Africa continent. Then there's a shift that is happening, and a realization is coming to a point is being made where faith-based are key in providing the last mile service provision when it comes to health. So there's a strategic shift maybe when it comes to donor funding and maybe partnerships where they really want to engage faith-based assets. And so HRP wants to document that and be able to have basic ways of being able to describe what capacity they have around health provision around. Then again, when you're aware of what you can offer and what you have, you're able to get and sit around in round tables and create opportunities and also partnerships. So the reason why HRPs in this is being able to see how we're able to create a central repository for us for all the assets that we have through our member CHs and member organizations. We need to be able to account and clearly represent what the Christian assets in Africa contribute towards the national and also regional data when it comes to health service provision. It's a clear way of being able to bargain and be able to sit around tables and negotiate for partnership and also in health service provision. And again, last and not the least, we want to create a learning community around Christian health assets and services provided. So that with that, we'll be able to reach the scope, scale, and also impact if we're able to map all the health assets that HRP has within its members. Back to you, Dan.
Wonderful, Dennis. That really paints a picture. And thinking about you mentioned the statistic, and I know we've talked about this a lot. 5,000 health facilities as a key advocacy point or a key education or information point. It is surprising to me how often I quote that statistic. I'll ask somebody, how many Christian health facilities do you think there are in sub-Saharan Africa? And people will say, I know of 2 Christian hospitals in Kenya. I know of 1 in Cameroon. And they maybe get up to 100 or 200. And then I say, no, there's 5,000. And so, people's understanding is really exploding. And so now, literally, I have very senior people ask the question, who are the networks that have that data? How do we get to the organizations that actually know about those? And that's where HAP plays a pivotal role. So I know you're on a journey of discovery with your own members. And thank you for that. I don't know if you have any final thoughts for us.
Not really, Scott, but yeah, we are on a journey of discovery and be able to see how we bring these isolated data sets that are within our members and be able to create a central repository where even the members can be able to link and maybe reach out for networking purposes.
That's excellent, and that's something that this consortium we hope can help foster and support and help bring about. So yeah, thank you for that. We appreciate that so much. So I think everybody's now got a picture of what the need is for this consortium and where it fits in terms of improving the standards for data everywhere. Now let's turn to a slightly different context, which is broader focus on health system strengthening. And we're going to turn to Dr. Edwin Sam, who's been working with us very closely on the 30 by 30 Health Systems Initiative. And maybe, Dr. Sam, I can turn it over to you to tell us a little bit about what that is and why that's important for us and how mapping fits into that. So over to you.
Yeah, thank you so much, Doc. And thank you so much for the nice introduction too. In the context of overall health system development, generation of evidence related to faith-based health services and understanding the extent of FPO's participation within the country's health system is very critical. In other words, we can say, as he said, as the doc said already, it is about understanding the scale, scope, and impact of FPO's contribution. Understanding these about faith-based health services are very critical because health sector planning requires accurate, complete information of faith-based health services within a country's health system. And it's very important for global health advocacy to guide the programs and policies towards better health. And it is very important to facilitate joint efforts by Christian faith-based health services across the country, across the world, to maximize the efficiency, equity, reach, and ensure cross-learning and resource mobilization, and so on. Okay, 3030 Health System Initiative of CCIH aims to strengthen 30 health systems in which faith-based health services operate. And there are multiple goals, but the key goal is to, which I would like to emphasize here, is to gather evidence of stronger health systems of faith-based health services. As we know, we initiated this one in 2020, and we are in better policies and programs across the world. I would like to give some highlights about the scale, scope, and impact of this 3030 Health System Initiative. So far, there are 31 commitments from different parts of the world, and we had 21 commitments in year 1 and 10 in year 2. Commitments means agencies, actually. 31 agencies are there, actually. Of the 31 commitments, 16 focus on single countries and 15 focus on multiple countries, multi-countries, actually. Majority of the commitments are from sub-Saharan African region, followed by Asian region. On the other hand, it can be mentioned that majority of the commitment makers are from sub-Saharan region, followed by Asia. And what are the commitment areas? What are they committing for? Which is actually talking about this. It is about the scope, actually. The broad commitment areas are health workforce development, leaders of governance, service delivery, direct service delivery, and improving access to medicine supplies and diagnostic services, community services, improving health information system, improving health financing mechanism, and organization building. In terms of technical focus areas, majority of them, almost 75% of them, are working in involved in health workforce development, which include a capacity building, training, mentoring in multiple areas such as maternal child health, general health services, leadership and governance, quality management system, financial management, documentation, and so on, actually. The second most important commitment area is actually leadership and governments. All our faith-based service of commitment makers are actually involved in improving the leadership and governance in their own setup and also among the individuals. It includes TA technical assistance for policy development, program development, and establishing partnerships and so on. And significant proportion of people are involved in direct service delivery also. And 12 commitment makers are involved in improving access to medicine, and some of them are involved in health financing and organization learning mechanisms. And now the most important part: how can we understand the impact of it? Actually, how can we understand the reach? How it is actually resulting into better outcome? For that, we have developed key indicators for all the activities that are coming under each technical area of commitment, which will be submitted by the agencies every year. And it has got qualitative aspects such as case studies, success stories, best practices, and so on, actually. Some of the indicators I would like to highlight, and which will actually indicate the impact and outcome of this initiative, actually. And it will be people reach through various programs, and it includes the service coverage, inpatient and outpatient services, number of training programs conducted, number of personnel trained, community groups established, such groups involvement in health-related activities, and the institutions that were supported through this initiative, through these organizations, and partnerships established, and resource mobilization initiative, health financing activities that includes health insurance enrollment, and so on. We have multiple indicators to capture the impact of this initiative. And to sum up, based on this initiative, from this initiative, I would say that, CCH is able to bring together Christian faith-based health services under a common platform from different parts of the world. The most important part is that initiative is able to, it is providing a great opportunity to document and generate evidence related to the scale, scope, and reach of impact of faith-based healthcare services across the world. And there has been a great growing interest among the commitment makers for joint working, cross-learning, and integrated efforts. And we need to develop and implement appropriate strategies to create a joint working environment. And I'm sure that intensive efforts can expand the network that can provide evidence related to the scope and scale and impact for global health advocacy, for better programs and policies for equitable, sustainable, and resilient global health by 2030. Thank you so much for the opportunity.
Well, thank you so much for that, and we really appreciate all of the work. The 31 commitment makers you mentioned are voluntary commitment makers who, using their own resources, their own and conducting their own projects, have really wanted to articulate what they do, to give information about what they do so that everybody can understand that, but also to see how by linking together they can promote that cross learning. And that's the significant part also to me of the mapping initiatives is that it also gives a way for people to describe where they work and as well as what they do, but where they work, so that they can then recognize the commonalities and synergies. Can you highlight again, just tell us where these initiatives are? I'm curious about the single versus multi-country initiatives. If you could just unpack that a little bit about this.
Yeah, definitely. Actually, it is actually out of these 31 commitment makers, majority of them are from Sub-Saharan Africa, actually. And then 16 focus on single country and 15 focus on multiple countries, actually. And as I said earlier, the majority of the commitment focus on Sub-Saharan countries, followed by Asian region, and then we also have from Latin America and Caribbean, and Middle East and North Africa and Eastern European region, and we also have global operations. Two are actually globally operating themselves.
That's remarkable, because then if you're doing a project and you see that you can make a measurable impact in a local health system, then the question is, who else is also working in that same local health system, and how together can their efforts be brought together and multiplied or magnified? And sometimes I think some of the organizations out there may do projects, but they may not be thinking about how they can describe what they do in a holistic or in some way, a holistic framework or some way that rolls up to other broader impacts. So thank you, Edwin. I really appreciate your work. I don't know if you have any final thoughts about that. Otherwise, I have a couple of questions for the group.
Yeah, thank you. I don't have much comments, but then I would also emphasize that point that this initiative is able to actually guide people to document, do better data collection, analysis, and reporting also. And we have got very good experience with all the commitment makers. They're all really doing a lot in terms of using the data effectively for better policies and programs.
Wonderful. Well, so far today, and we're going to turn to a couple of questions. We've talked a little bit about CCIH's own efforts to understand our members and our new data and mapping working group. We've talked about the new consortium, looked at it from a technical lens as well as from HAP's perspective. And then we also talked about health system strengthening using CCIH's 30 by 30 initiative to help illustrate that. So these are exciting times to be involved in this. And there's a couple of questions that have come in. Please, we have 9 minutes, so we can cover some good questions in that time. Barbara, I think you're still there. There was a question that came. Do you have any demographic or health network data compiled so far for Haiti that is accessible to members? Demographic or health network data compiled so far for Haiti that is accessible to members?
Yes. So we have a website which I can type in the chat. it's under our URL relinkglobalhealth.org, but it's a subset of that. And for the Haiti data, we make public, free to anybody to use, the demographic and service data. So for example, in the country of Haiti, you can search by specialty like neonatology or dermatology or whatever the case may be, and find a facility in whatever department or region you're working in. And, you know, basic healthcare facilities, hospitals, all those things you can search for. Even medical equipment you can search for. Where is a CT scanner? Things like that. The capacity data that I mentioned that we're gathering, we do keep that private, but we are very willing to share it with anybody who asks. And if I don't know who asked the question, but I'm happy to share our capacity data report for Haiti for anybody that's working in Haiti, and it would help.
I can tell you the question was asked by Dan Irvine. The problem is that we have 2 Dan Irvines in our community, so I'm not sure which one.
Oh, I know which one it is.
Okay, all right, well, there you go. There you go. There was a question that came, a comment that I'll get to in a moment, but a question that came in. Can you share more about the timing of the consortium's efforts? Scott, do you want to help tackle that? What do you think is the timing that we're working towards?
Well, thanks, Doug. As you know, the consortium is meeting every month, and we have been initially developing the registry of data sets for the group of founding partners themselves. We're hoping to be able to analyze and compile and analyze some of that information to start developing aspects of the platform that will reflect data that we currently have and are able to look at. I think that's going to take us into, you know, the early part of 2022, and that sometime within the first to second quarter, you know, I believe we're looking at a potential launch in the first quarter, but there are many moving parts that are trying to come together. And at this stage, we have a charter that is under development, mostly finalized, as you know, but all of the organizations involved have to sort of vet that and sign on before it is fully authorized. So that could be a short or long process, but it will definitely be happening and launching in the early to middle part of the coming year, we trust.
Yeah, thank you. I like that you put it that there are a lot of moving parts on this, and that's why we wanted to get this out there so that people could begin to know that this is something that's in formation. And the charter's in draft stage right now. If you'd like more information about this, please feel free to reach out to us. We'd be happy to give you some more updated information around that. There was a comment that came, which I would love I'd love for people to help process for a moment. I'll just read the comment. It was, there's a change happening whereby many Christian healthcare professionals are intentionally moving into secular or state-run systems to be a channel of intentional influence in many nations of Southern continent. These people are going to be key in influencing healthcare systems. This might be another project to consider, Christian healthcare manpower, manpower asset mapping. So that's a dimension. We've been very institutional or organization focused in our thinking on the consortium. We've really not tackled Christian health professionals. I know we have ICMDA as one of our members on the consortium, and they really are really out in front in terms of physicians and dentists, but I don't know beyond that who is tracking that. Any comments from members about that? That's quite an intriguing point.
Well, I would just say this is certainly something that many of us who have been working, you know, with health facilities, with human resources in health in developing countries have recognized, whether intentionally or not. There are many facilities, many Christians and individuals who are seconded from maybe from a Christian health facility into a larger district or county or state health facility. And so this moving around of human assets has been going on for some time. And it's recognizing these intentional efforts at moving that way. You know, to me, it's certainly reflecting of the character of Christ and going into all systems and everywhere to bear witness to, you know, his love and healing. So I think this is, you know, that's just really a good way of acknowledging and, you know, continuing that movement, recognizing that, you know, as a mustard seed kind of expands bigger than what you could believe, the Holy Spirit guides Christians to work in every context that we have. And I think that we should be open to all of that leading.
Thank you. Yeah, I appreciate that, Scott. There was a question, one specific question that actually has a longer tail to it. I think Bruce Compton asked Barbara, how often is the data in Haiti updated?
Sorry, excellent question. We try to get to it every year. I would be lying if I said it's 100%, particularly for those of you that know Haiti. Anything in or around Port-au-Prince right now is not very safe, so we don't go there as often as we would, but we have our staff rotate through the different facilities every year, and we encourage facilities to update their own organization in between that, but not 100%.
Yeah, thanks. And that the longer tail of that is anybody who has data on local assets, that things change. Now, Barbara, you made a really interesting point a year or two ago on this, that things change, but they don't change that much that fast. And that's an important thing. So we do have to keep the data updated. And so whoever creates something has to think about that. And that's part of what the consortium is thinking about. There was an important comment from Perry Jansen about some of the folks don't want to be mapped for security reasons. And we're very careful, for instance, when we think about the consortium, we don't want to be a data warehouse, or we recommend the consortium not be a data warehouse of all manner of Christian health data, including contact information. But that's a security concern. I wonder, Dennis, Edwin, if you have any particular thoughts about that, and we just have a minute left. I don't know if you have a quick comment about that. Dennis or Edwin, any quick comment about security of the data and security of the facilities?
Yeah, and maybe a comment around that is sure, most of these individuals don't want to be mapped and they don't want to be known where they are. But looking at what the consortium efforts are, and when we're mapping the assets, we're also trying to look at training centers that are Christian-led, and maybe with that we can be able to clearly showcase the contribution that Christian health assets are making towards the manpower available in healthcare settings in the various places where we work in.
Thank you.
Yeah, I do agree with that. Actually, there are some fear among people to be mapped. Actually, no doubt about that. And I don't know how to address this issue, frankly speaking.
Yeah, that's a tough one. And there's a final comment that we don't have time to unpack, unfortunately, which is how long does it take realistically to map services for those who have for those who've done it? How long does it take to actually map? That's a complex question. It depends on what we're trying to map, doesn't it? If you're trying to geoplot hospitals versus you're trying to map Christian community health programs, it really varies. I know we're at time, but does anybody have a very specific comment on that, about how long it takes?
I can share a little bit about our approach in Haiti. I mean, I think a lot of times we have a mental block on how long this takes and how hard it is. And I think sometimes you just need to think, well, maybe it's not as hard as I thought. And along with the accuracy of the data too, you know, we always say, would you rather have the data 95% accurate and 5% wrong, or have none of the data? You know, so we always are trying for 95, 98, 99, 100% accuracy, acknowledging that we'll never get there, but we still feel that having that data there is better than having no data available at all. So that's kind of one of our mottos on that. And as far as time-wise, we would set up a department in Haiti. We'd have a list of all the facilities prepared. We'd work with the Ministry of Health, and our staff would visit every facility in a department in about 3 weeks. I mean, it was like a blitzkrieg. In that department, everything go, they were prepared to go, and then they bring the data back, and then we spend the time in the office. One person enters it, another person audits it. So it really wasn't as long as you think. So you take Haiti, that's got 10 departments. West is not done yet, but the 9 of them are done. A 3 to 4 week project in each department got it done. The initial collection.
I love the tangible expression there, and don't aim for perfection. What's the phrase? Don't let the perfect be the enemy of the very good. So let's aim for getting something where we really lack a lot of good information right now. Getting something better. Friends, we thank you for joining with us. We're really at the end of our time, and we have other questions that are starting to come in, and we'll do our best offline to respond to some of those. This has been really enlightening for me. Thank you to each of the panelists. Really appreciate your insights and your perspectives. Let's see now. Please let us know what you thought about the webinar. This is important. We love hearing from you. You see a link in the to a form in the chat box. With only one question, giving us feedback about the webinar. One question. We're data and mapping, friends. You can do this one question. It would be really great if you could click on it and give us some feedback. Your answer will help us with our programming. Kathy will put that in the link. With that, everybody, we thank you so much for participating today. Hope you have a great rest of your day or evening wherever you are. Thanks so much.